So I want to welcome everybody that's here to the Covenant Health Center Lunch and Learn. We have these from time to time, and please check the Covenant Health Research and Events page to see when our next one is. I just want to do a little bit of housekeeping here. So as I mentioned, for the people that just came in, we will be recording this session. Please keep yourself on mute till the presentation is over, and we will open up the floor to questions, but please feel free to post questions in the chat. We have people monitoring the chat for the questions, and Dr. Raisman will address them at the end of the presentation. There will be polls during this presentation, so they'll be popping up at appropriate times. So please answer the polls, and an evaluation will be sent immediately after this presentation. So I would like to acknowledge, in the spirit of reconciliation, we want to acknowledge that this gathering is taking place on traditional lands across the province of Alberta, home to many diverse Indigenous, Métis, and Inuit peoples. Spanning generations, acknowledgement of the land is a traditional custom of Indigenous peoples and an important part of reconciliation. It gives voice to the authentic history of the land and its original people. Honoring the land in this way acknowledges the story of the creation of this country in a way that has historically been missing. And I will credit Kim Tackaberry. So, Dr. Josh Raisman is a clinical biochemist with Alberta Precision Laboratories and an associate clinical professor in the Department of Laboratory Medicine and Pathology at the University of Alberta. He supports chemistry testing at the Misericordia, Grey Nuns, Royal Alec, and Sturgeon Hospital labs. One of his interests is involving undergraduate students in hands-on laboratory projects, then applying this work to solve laboratory problems. This is exemplified in the work being presented today. And with that, I will turn it over to Dr. Raisman.
Okay, I'm just going to pull up my slides.
We can see your slides.
Okay, do you hear me okay?
Yes, we can hear you.
All right, perfect. All right. Sorry, let me just scroll back. Okay. Well, thank you to the Covenant Health Research Center for the invitation to present our work today. As Rhonda mentioned, the presentation title is Seeing Beyond the Hue, Impact of Hydroxycobalamin, which is also called Cyanokit, on laboratory tests in patients with smoke inhalation injuries. And I'm going to be presenting on this project that's been going on for a number of years now, probably close to 4 or 5 years that we've been working on this. Predates Connect Care, actually. And we've had a number of medical lab science students out of the University of Alberta who have done some research at the Misericordia and Grey Nuns Hospital to contribute the data here and come up with this new protocol that we have developed, and I'm happy to share it with you. So the objectives today are to describe the use of hydroxycobalamin and its impact on laboratory tests, identify specific analyzers and tests that are affected by hydroxycobalamin interference, apply strategies for mitigating interference, identifying samples and reporting results, and lastly, to practice multidisciplinary collaboration between the laboratory clinicians and pharmacists to provide solutions for hydroxycobalamin interference challenges. So I'm first going to start off with a case that I feel best exemplifies one of the biggest challenges the lab faces on this topic I'll be presenting on. Pretend you are the on-call biochemist like myself and get paged at 3 a.m. in the morning. You answer the call and your lab techs tell you that that there's a recently collected plasma sample that I show over here on this right panel. This is from the ER and it looks hemolyzed with a reddish hue, but there are no hemolysis flags or errors on your analyzer that would suggest anything that is wrong with the sample. The sample happened to be discovered inadvertently when it was manually run on a different analyzer for plasma osmolality. In previous samples were not identified because results did not require any tech intervention and were automatically released to the patient chart. There were several tests like electrolytes, liver function, kidney function, glucose, lactate, troponin, a complete blood count or CBC, and coagulation test results that have already been released to the patient chart. Your lab tech is concerned about reporting out erroneous results because the sample is unusually red. So based on the information I just provided, and Rhonda, please pull up the poll. So the information I provided on the red sample collected in the ER with no flag, what is the best immediate action that you would take? So the first is that results are reliable, take no action, go back to bed. Results are reliable, cancel all previously reported results and future orders. Ask your tech to perform dilution studies to investigate for interference, or do a literature search to determine source of red pigmentation.
33% of results are unreliable, and 67% were ask your tech to perform dilution studies.
Okay, that makes more sense. Okay. Thank you very much, Rhonda. Okay, all right. So we'll walk through some of the information that I have, and some of the answers hopefully will become clarified. But that's a reasonable choice to ask your tech to perform dilution studies, and also reasonable to think that the results are unreliable, and I will be showing you why right away. So let's get back to the case. The patient is a 45-year-old male brought to the ER by Emergency Medical Services, or EMS. The patient was vomiting, wheezing, shortness of breath with altered mental status. The patient was a victim of a house fire. There was soot around his lips, nose, back of mouth. Mydriasis was noted, which is dilation of the pupils in the eye. And the chart says that a 5 milligram dose of cyanokit was administered by EMS at the scene of a house fire. Blood work was done immediately after the patient arrived in the ER. So this is the next poll. Identify which of these plasma samples was drawn immediately after ER admission. So we have sample 1, sample 2, sample 3, or sample 4. Each have slightly different colors, although sample 1 to 3 are very similar looking. And so which one of these plasma samples was drawn immediately when the patient was transferred to the ER?
We have the results. So 67% for result 1 and 33% for result 3.
Okay, interesting. Okay, so sounds like everyone either selected 1 or 3. So the answer is actually 2. And this is the point that I wanted to really make. Sample 1 is from another patient and is grossly hemolyzed for comparison purposes. So it's not even collected on that patient. Sample 2, 3, and 4 were drawn after cyanokit was administered at different time intervals. So 11 minutes was sample 2, 4 hours is sample 3, and 6 days is sample 4. So you can see that sample 1, 2, and 3 are almost impossible to distinguish by eye. They are all red and appear to be hemolyzed. And I'm going to talk a little bit later that identification of these samples is a major challenge for us in the laboratory. So there's the answer right here. Okay, so fire-related injury and deaths in Canada are increasing. According to Statistics Canada, there were over 1,600 residential fire-related deaths in Canada between 2011 and 2020. This amounts to about 4.3 deaths per 100,000 people who are greater than 44 years of age. And fire deaths are not always due to trauma from burns. There is a large fraction, or about 68%, that are due to smoke inhalation injuries alone. Smoke inhalation deaths are often attributed to various toxic gases like hydrogen cyanide, carbon monoxide, and other toxic vapors. This is data from the Canadian Institute for Health Information, or CIHI, and it shows that the percent of ER visits due to fire causes across Canada are increasing from about 5% of visits in 2017 to 2019 up to 6% in 2020, and then more recently to 7%. And then most recently, fire exposure has been all over the media. Many people have likely are aware of this, especially this past winters, with many cities across the country seeing a rise in homeless encampments. And also we can't forget about the increasing rate of forest fires around Alberta and the rest of the country. Cyanide is one of the most rapidly acting and fatal poisons. Where there's smoke, there's often cyanide present, with smoke inhalation the most common cause of acute cyanide poisoning in closed-spaced fires. Hydrogen cyanide is produced from burning of synthetic and natural materials under high temperatures and low oxygen conditions. Sources include a variety of construction and building materials, as shown in this photo. It could be from glass fiber, rubber, insulation foam, various kinds of laminate. It rapidly diffuses into tissues, resulting in fatal cellular hypoxia that then results in neurological depression and cardiorespiratory failure. If it's not treated early, death can occur in as little as 10 minutes. And plasma lactate can be used as a surrogate marker of severe hypoxia with levels equal to or greater than 10 millimoles per liter that are often seen in patients with cyanide exposure. The mechanism of cyanide toxicity is through inhibition of mitochondrial enzymes responsible for oxidative phosphorylation. Here is the normal electron transport chain in the inner membrane of the mitochondria, as you might recall from high school biology. These protein structures called cytochrome C and cytochrome A, they're responsible for creating a proton gradient in the presence of oxygen to synthesize ATP. And remember, ATP is the main energy source that drives all cellular activity and enables the body to function. What happens under cyanide exposure is that cyanide binds to these cytochrome complexes and blocks its ability to generate a proton gradient, and that effectively stops oxidative phosphorylation and generation of ATP. So what happens is that oxygen is no longer able to be utilized, so cellular energy production shifts away from using oxygen to using lactate under anaerobic metabolism conditions. And that's why we often see elevated lactate, which causes lactic acidosis in these patients. The antidote for cyanide poisoning is hydroxycobalamin. It is a form of vitamin B12. It works by binding cyanide to its cobalt metal structure shown here in the red circle in a 1-to-1 ratio to form cyanocobalamin. And it's the cyanocobalamin that becomes non-toxic and can easily be cleared by the kidneys into the urine. Inhibition of the cytochrome complex in the mitochondria, it's reversible. So once cyanide is neutralized by hydroxycobalamin, oxidative phosphorylation can resume almost immediately. An initial dose of 5 grams is administered by intravenous infusion or IV, but depending on the severity and the clinical response, a second 5-gram dose may be administered, totaling up to 10 grams. The onset of action is very rapid and can prevent death in minutes if given at the right time. And then I'm going to show you just a little bit of some pharmacokinetic characteristics of the drug that helps characterize its effects. So we have here the volume of distribution. That is low. What this means is that it is widely distributed mainly in the circulation rather than in the tissues, which further means it has minimal toxicity. And the half-life is 26 to 31 hours, which means that if you look at 5 half-lives, which is what we use to look at the level of drug to stabilize over time, it can take anywhere from around 6 days or more to be cleared from the circulation. Urinary excretion rate is 60 to 70% of the initial dose after 72 hours, meaning that is primarily eliminated by the kidneys. Hydroxycobalamin is approved by Health Canada for treating smoke inhalation injuries, but there is increasing interest in using it as an off-label treatment for refractory vasoplegic syndrome post-cardiac surgery. And vasoplegia, this is a condition that causes uncontrolled vasodilation of blood pressure, leading to severe low blood pressure. So there's a bunch of uses for it, but the primary use is in treating cyanide poisoning due to smoke inhalation. Cyanokit is the most well-known and commonly used brand name, and I'll be interchanging this term with hydroxycobalamin for the rest of the presentation. It comes as a kit, as you can see here. In Alberta, the cost is $1,057 for this kit. It comes in a 5-gram vial of lyophilized or powdered material containing hydroxycobalamin, and then there's an intravenous infusion set that's included as well. To prepare it, saline has to be added to the vial to reconstitute the powder, and then it is administered intravenously. Cyanokit is administered only under certain clinical scenarios. In Alberta, EMS and the ER follow a provincial clinical cyanide poisoning treatment protocol, as I'm showing over here. This is an excerpt from that protocol showing that cyanokit is administered to patients if there are known or suspected risk factors for exposure. and when the patient meets certain Glasgow coma scores or cardiovascular signs and symptoms. So not all patients who are victims of house fire are going to receive Cyanokit. They have to meet these criteria in order to receive the Cyanokit. And here's a number of figures here showing the frequency of its use in the Edmonton zone over this past year. You can see here, out of the 22 kits used in this past year, a large proportion is administered in the hospital setting. ER used 41%. Intensive care units, or the ICUs, used 5%. Operating room, or the OR, used 18%, and 36% given by EMS. In Alberta, there's a specialized EMS service called the Incident Response EMS, or IREMS, that manages emergency involving hazardous materials. And it is this IREMS personnel that are the only qualified EMS personnel that are able to carry Cyanokit and administer them either on scene or in the ambulance. In Edmonton, patients are often sent to the Misericordia Community Hospital because of availability of a hyperbaric oxygen chamber to treat smoke inhalation injuries, but they're also commonly sent to the University of Alberta Hospital. So we see these patients most commonly at these two sites, but oftentimes patients can go to the other larger tertiary care centers in the city as well. As I mentioned before, Cyanokit has a very good safety profile, but it does have some side effects. One of the side effects is elevated blood pressure, and that is the reason why it is used off-label for vasoplegic syndrome I mentioned earlier. Allergic reaction and a rash can also occur, but this is rare. The side effect that's going to be most relevant here is that it turns skin, urine, plasma, and mucous membranes red. This photo shows the bright red discoloration of a patient's skin and the urine after treatment. Most importantly, hydroxycobalamin imparts this red hue to plasma samples. And what I'm showing here are the different shades of red in plasma collected from a patient at different time points after Cyanokit was administered. The first two samples show what normal plasma looks like next to a grossly hemolyzed plasma for comparison. And you can see that the red hue starts to significantly fade by 3 days. But even at 6 days, you can still see a slight shade of red, and this has implications for designing our lab reporting protocol that I'm going to touch on later. It's no surprise that this red pigmentation is known to interfere with lab tests, specifically methods that use optical light or spectrometry on our analyzers to generate a signal that we measure in our assays. This is the hydroxycobalamin absorption spectra showing the light wavelengths it strongly absorbs at. I'm showing this because these peaks tend to overlap with absorption peaks that are common in the chemicals we use in our assays to report the results for many different tests. For example, here I have liver enzymes, creatinine kinase, glucose, lactate dehydrogenase, and urea. These employ reactions involving NADH, NAD+, which has a wavelength absorption around 350 nanometers and overlaps with the strongest hydroxycobalamin peak right here. So these tests have the potential to be affected. This Jaffe reaction is commonly used for creatinine measurement and also overlaps with the secondary peak. And we have Trinder-based assays. These are redox reactions that are also used in measurement of creatinine, as well as other tests like lactic acid, glucose, urate, and they also absorb near the secondary peak. Measurement of hemoglobin using spectrometry and other tests like bilirubin and total protein also show overlap. And then there could also be overlap with other tests as well that I'm not showing. But essentially, the overlap of these peaks can potentially interfere with measurement of these tests and cause false results that can either go up or go down. And so this is why it's very important that we understand the interference spectrum of hydroxycobalamin and develop protocols. So we developed a protocol to handle and report these samples from patients who are administered the drug. We call it the CFLAME protocol, or the Cyanokit Facilitating Lab Analysis and Managing Errors. The project started way back in 2019. At that time, we performed interference experiments across various analyzers for chemistry, urinalysis, hematology, coagulation, and blood gas instruments that were being used at the Misericordia Hospital and across the major urban hospitals in Edmonton. And at that time, that led to development of the first protocol. But then in 2021, there was a large wholesale changeover of analyzers in the laboratory. We went from Beckman to Roche for chemistry, for example, Beckman to Sysmex for hematology, Stago instruments were switched to IL TOPS analyzers for coagulation. So we had to redo our experiments on these new analyzers. And also we added in some more studies on different analyzers that are currently available, like the OrthoVitros analyzers that are used at smaller hospitals in the suburban rural communities. And then we also performed some dilution studies to determine if dilution could actually minimize interference in the sample and allow us to report highly impacted results. So that led to development of the second version of the protocol. But the challenge has always been identification of these samples in the lab. As I showed, the color is very similar to hemolysis, and so it's very difficult to distinguish between those two very different conditions. So this past year was really focused on developing strategies to improve identification. And that led most recently to development of a third version of the protocol, which I'm going to show a little bit later. And currently the protocol is restricted only to Edmonton Hospital labs, but the goal will be to expand it out provincially to other relevant sites across the province, hopefully in the coming year. We designed our interference studies largely based on CLSI standards, which provide standardized guidelines for laboratory practices. In the first phase, we performed studies at the Misericordia Hospital, and this was actually published in 2021 in a clinical biochemistry journal. The study involved pulling normal and abnormal patient samples from storage in the laboratory that we had in our freezers, and then we divided the samples into spiked hydroxycobalamin groups and unspiked controls. And Pharmacy at that time was kind enough to provide the hydroxycobalamin for our studies from expired cyanokits. Now, we chose 1.5 milligrams per ml as the starting spiking dose because this was the common concentration that was found in the literature and also generally matches pharmacokinetic studies, showing the peak blood levels to be 0.579 after a 5-gram dose is administered. But remember, previously I showed that sometimes patients are given double the dose up to 10 grams. So the 1.5 milligram per ml spiking dose used in our study reasonably matches what would be expected in a patient if they're given double the dose. And then we use a 10% interference goal as an initial evaluation of interference. And if this was exceeded, we went on to do dose response experiments with increasing concentrations to fully characterize the interference effect. And then when we switched over to the new analyzers a couple of years ago, we had to reperform similar studies on these new analyzers. And that most recent work was done at the Grey Nuns Hospital lab. And in that most recent protocol, if a 10% interference goal was exceeded, we went on to do dilution studies to determine if interference could be prevented in the sample. Now, we used several metrics to determine if the spiked samples showed significant interference, which would further help us determine if results from those tests on those patients would be reported. And as I mentioned, initially we used a 10% interference goal as an initial interference assessment to decide if further studies like dose response would be performed. We also used an acceptable change limit, or ACL, to determine the degree of interference for reporting decisions. And ACL was based on something called biological variation as well as analytical variation. To determine if certain tests could be canceled or reported, we categorize interference into 3 groups. We had minimal impact. These are the tests where interference is less than 10% and the ACL is not exceeded. These tests are reported to the patient chart. We have moderate impact tests, where interference is between 10 and 20%, but the ACL is not exceeded. These are reported, but with an interpretive comment. And then we have the high impact tests. These are the ones where interference is higher than 20%, or the presence of analyzer errors and the ACL is exceeded. So these are the ones that we don't want to report to chart because there are likely false results and they could be misinterpreted. Here are all the analyzers and all the tests we performed spiking studies on over the course of our 2 phases. It was no surprise that tests that use spectrophotometric chemical methods, like I described in a previous slide, with absorption spectrums that are most similar to hydroxycobalamin, those are the ones that are going to be impacted. And you can see the liver function test, kidney function test, that was common across the different instrumentation. But we also found that interference was also unpredictable. Immunoassay tests that use antibodies in the detection system are largely unaffected. Those are things like troponin and BNP tests, as well as HCG. Except for conventional troponin I on the Beckman axis, and a number of fertility hormones on the Roche Cobas E801 instrument, those actually showed some surprising interference. Hemoglobin and red blood cells are hematology tests that were both affected on Beckman DXH and Sysmex. So that was not surprising, but an unexpected finding was that the coagulation tests like PT-INR and APTT were impacted on both STAGO and IL-TOPS instruments. Many of the urinalysis dipstick pads were also affected. And on the radiometer, ABL, blood gas analyzer, the co-oximetry parameters, hemoglobin, hematocrit, carboxy, MET, and oxyhemoglobin were also impacted. This is an example of our reporting scheme from the first phase of the study. This is published. The high impact tests are also called, the high impact tests, we also call test analytes in the lab, just so you understand the use of that term here. So those are the high impact tests are the ones where there's greater than 20% difference in the interference, or when the ACL is exceeded based on analytical and biological variation. And our protocol is to cancel these tests. And you can see there's a number of these Beckman tests, AST, CK, creatinine, enzymatic, as well as the creatinine Jaffe test, magnesium, total bilirubin, total protein, uric acid, those were significantly impacted. For coagulation, we found that D-dimer, PT-INR, APTT, and anti-10A were impacted on the STAGO analyzer, and those tests would also be canceled. On the radiometer ABL blood gas analyzer, hemoglobin, hematocrit, and the co-oximetry parameters were highly impacted and would also not be reported. On the Siemens dipstick pads, we had ketones, nitrite, leukocyte, and blood. Those were significantly affected and would not be reported on the urinalysis panel. Then we have the moderately impacted tests, where the interference was between 10 and 20%. Those are listed here. These are reported with a cautionary comment. Lactate is included in this group, but the reporting comment indicates to confirm results on the blood gas analyzer where lactate is unaffected. And then the unaffected analytes are listed at the top. These are the ones that are reported to the patient chart. Here's an example of our dose response interference studies where we spiked samples at increasing doses of hydroxycobalamin. You can see that most had a nice linear dose dependent interference effect except for conjugated bilirubin, where results in the normal range had negative interference, whereas results that were above the reference interval had this kind of positive or biphasic pattern, which was kind of almost unpredictable. But for most, you can see that interference even existed well below the maximal dose of 1.5 milligrams per ml, even for some tests as low as 0.2, like total bilirubin and total protein. So what that is suggesting is that interference is likely significant even as hydroxycobalamin is cleared by the kidneys hours and even days after the initial dose is given to patients, and that results may continue to be unreliable until it is entirely cleared, which could be days or weeks. And it would be extremely difficult or nearly impossible to predict a specific threshold where interference stops because the interference appears to be very much dose and test dependent. What I'm going to do in the next few slides is show summary data for select tests on different analyzers to give you some perspective on what the interference actually looks like. Here is the chemistry data on different analyzers. We have Vitros in blue, Roche in black, and Beckman in the red. And the asterisks indicate that the changes exceed the ACL. You can see there's significant variability between analyzers. So for example, one of the liver enzymes, ALT, on Roche in the black, had a negative interference of 29%, but the interference was lower on Beckman with a negative 13% change, while on Vitros in the blue, there was an analyzer flag, an error flag that came up on the analyzer. So there was no result that was able to be produced. If we look at total bilirubin, This was the most effective test across all the 3 analyzers, but the direction of interference was different. There's a positive interference on Vitros and Beckman and a negative interference on Roche. We have here the creatinine enzymatic method on Roche. This was minimally impacted, but was significantly impacted on Beckman, while the Jaffe method showed a large positive bias on Vitros with a negative interference on Beckman. Lactate over here, this was highest on Vitros at 85% and lowest on Roche at 7%. Electrolytes like potassium was unaffected. Troponin was a bit variable. No interference was seen on the high sensitivity troponin T Roche assay that we're currently reporting out, but there was a moderate impact on the Beckman conventional troponin assay with a 7.2% decrease. Here is the hematology and coagulation results. It's no surprise that hemoglobin showed positive interference, and that was consistent across both of these analyzers that were studied, because the absorbance falls within the hydroxycobalamin wavelength spectrum, but the magnitude you can see is much higher on Beckman compared to the Sysmex. Interference on PT-INR, APTT, and fibrinogen were unexpected findings because these assays use a clot-based detection system. They don't use spectrophotometric, while interference on D-dimer and anti-10A were predictable because they actually use a spectrophotometric detection system similar to chemistry. And we think that the falsely prolonged results for PT-INR and APTT is due to a direct effect on clotting in the assay, not necessarily a biological effect, because as I've shown before, hydroxycobalamin is not known to have any coagulopathy side effects. D-dimer seemed to show the highest interference. That was on the Stago instrument, but no interference was seen on the IL TOPS instrument, which is currently being used right now. Anti-10A is a third-party reagent used on both analyzers and showed a negative interference of 30%. And fibrinogen is also a clot-based assay with significant interference on IL TOPS, but minimal interference on Stago. We also looked at interference on the radiometer ABL 835 blood gas analyzer by collecting whole blood samples from healthy volunteers. And what I'm trying to show here is that the co-oximetry parameters are affected. There were analyzer flags at the highest dose of 1.5 and 0.8 milligrams per ml of the spiking dose that we used. But at the lower doses of 0.2 and 0.4, you can see that there was this dose-dependent effect with hemoglobin slightly increasing from 2.8 to 3.1. Oxygen saturation, oxyhemoglobin, carboxyhemoglobin, these showed negative interference with carboxyhemoglobin decreasing by 43% at 0.4 milligrams per ml. Methemoglobin showed a positive interference of just over 200% at also 0.4. Keep in mind here, the limitation is that carboxy and MET results are expected to be very low in a healthy volunteer, which makes it challenging to interpret changes at such low concentrations. But nevertheless, clinically, carboxyhemoglobin levels would be evaluated in patients with smoke inhalation injuries, so interference would be important to be aware of because falsely low results could lead to misleading diagnosis of carbon monoxide poisoning. We next looked at whether it would be possible to minimize interference by performing dilution studies on the hydroxycobalamin spike samples. This is a graph showing 5 times and 10 times dilutions on 5 impacted chemistry assays, and the error bars represent the standard deviations. The bars show the percent change from the unspiked control sample, so a change closer to 0 would indicate no interference. That's what we were really looking for. What we found was that with increasing dilutions, you can see the error bars tended to become lower, indicating that dilutions may be effective. But the problem here is that there's large fluctuations as shown by the error bars, suggesting that dilution is actually quite unreliable and unpredictable. CK, creatinine kinase, was the only test that showed minimal fluctuations across both dilutions with tighter error bars, indicating that it might be possible to dilute CK before reporting results to report out reliable information. But ultimately, we think that the best practice is to prevent interference in the first place by collecting a pre-dose sample on the patient before Cyanokit is administered to establish a baseline for comparison with subsequent post-dose samples. This is really not practical in most real-world clinical settings because either Cyanokit is administered before the patient arrives in the ER, or there is no time to do blood work in a busy ER setting because the priority is really to treat the patient over drawing blood. So we've been very unsuccessful to get a pre-dose sample. So after completing our interference studies and generating a list of tests that should be reported and a list of tests that should be canceled because of the risk of producing false results, we explored different strategies to best identify cyanokit samples in the lab. So Rhonda, please pull up the next poll. What would you consider the best strategy for the lab to identify cyanokit samples? 1, visual identification. 2, memo to the ER asking clinicians to phone the lab. 3, a digital alert in the automated drug dispensing cabinet. 4, hemolysis flagging rules. Or 5, lab information system auto verification rules.
14% for visual identification, 43% for memo to the ER, 43% for digital alert, and 0 for hemolysis and for LIS auto verification.
Okay, great. So I'm going to walk us through each of these strategies and tell you what worked and what didn't work. Visual identification, that's what we first explored. If the samples could be simply visually identified, but we quickly learned that this was not a one-size-fits-all strategy because it's dependent on our techs having enough experience to differentiate cyanokit from hemolysis. Also, labs with automated pre-analytic lines where there's minimal tech handling because it's all automated, this is going to miss these samples because there's minimal handling. So visual cues didn't work well for us. We next explored whether clinician engagement would work. We sent out lab bulletins and gave presentations to the ER staff asking them to notify the lab when cyanokit was administered, either by the EMS or directly in the ER. We never received any phone calls and could not achieve good compliance with the calls. So this was not a reliable option. Another idea was to work with our pharmacy team to develop a prompt that would flash on the drug dispensing safety cabinet screen when cyanokit is administered in the ER. And this is an actual screenshot of what the alert would look like. We suggested the message would tell the nurse to call the lab before sending lab orders when cyanokit was administered. We only got to the testing phase and we didn't actually implement this alert because after further discussion, it was felt there would be a lack of compliance with nurses who would also ignore the similar messaging as our communication bulletin. So we did not pursue this idea any further. We then looked at whether cyanokit would be triggered by hemolysis flagging on our analyzers, and in this way we could develop rules to hold the results before they're actually reported. All of these major automated instruments by these manufacturers of these chemistry analyzers have the ability to provide semi-quantitative measures of hemolysis in the sample, and this is really used to detect if there's in vitro hemolysis, which is an artifact, and we can then develop reporting protocols so that we're not reporting out erroneous results because of in vitro hemolysis. It's really a quality measure that's used by labs to prevent certain results affected by hemolysis from being reported. So the hemolysis index measures the amount of hemoglobin essentially in the sample, and that's a result of damaged red blood cells. And because hemoglobin is one of the tests impacted by hydroxycobalamin, we thought it would be possible for our hemolysis index to also be flagged. So what we did is we performed a study using banked cyanokit samples and binned them according to time groups after administration. So we had 0 to 6 hour samples after cyanokit was administered, 7 to 9 days, all the way up to 7 to 9 days. And we also created controls consisting of normal plasma, hemolyzed plasma, and also spiked with hydroxycobalamin. And then we sent out aliquots to various labs across the country in the US that have these major platforms, just as a comparative interest, including our Roche Cobas Pro instruments that we're currently using at the MIS and Grey Nuns, as well as the other major tertiary care centers in Edmonton. And then we generated these hemolysis index numbers across the analyzers. They are really not standardized across the analyzers. They produce different numbers. So to directly compare, we came up with a grading scheme. 1 was designated if there was an error on the analyzer, 2 if there was no hemolysis, 3 for slight, 4 for moderate, and 5 for gross And on this table, I'm showing the heat map with the average grades for each bin and the corresponding color codes. And I'm showing here the hemolysis index for Roche because this is what we're currently using. And then here are the other platforms just showing the average grades. But what I really want you to take away here is that you can see the flagging was highest within the first 12 hours, so the darker red in the first 12 hours after Cyanokit was administered, either with an air on the Vitros here or moderate on Roche and slight for the others. And after 12 hours, the flagging decreased to slight to none for most of the platforms. You can see in the lighter shades of red. On Roche, the highest index value was 182 within the first 6 hours. Right there, you can see 182. And the importance of this in our lab, where we're using Roche chemistry analyzers, the lowest hemolysis cutoff that would hold results and prevent them from being reported is 200. So that means for us, Cyanokit would not trigger a high enough flag to hold results and allow our lab techs to investigate the sample and possibly identify Cyanokit. So ultimately, this strategy was not effective for us to identify Cyanokit samples. So what we came up with was another more robust strategy, and this was to build a rule in Connect Care. And what the rule does is it links Cyanokit prescriptions in the patient chart to lab orders. When Cyanokit is ordered, as shown here in the screenshot, this is a mock patient, it will trigger a hold rule on chemistry, hematology, coagulation, and urinalysis tests. This is an example of ALT showing activation of the hold rule. That's going to stop results from flowing automatically to the patient charts. The results then need to be manually verified to release them. So this hold rule really allows Cyanokit samples to be identified in our Cyanokit reporting protocol to be applied so that impacted results are going to be canceled and the non-impacted results are going to be released to charts. And then once we know a patient has been administered Cyanokit, we're able to put a flag on the patient's chart that's going to hold subsequent lab orders and prevent them from being automatically released. The limitation, though, is that the rule will only pick up patients given Cyanokit in the hospital setting. It's going to miss cases where EMS administers it because EMS is currently not on Connect Care, so this rule will not be activated. We estimate the rule would miss approximately 35% of these cases. And we are currently working with EMS to find a strategy for them to contact the lab in these scenarios. To ensure EMS administers Cyanokit, and that's going to be identify the lab, what we have agreed to do was to append a label to Cyanokit boxes in the ambulances, prompting the EMS to notify the lab. And the EMS would call the laboratory as soon as the patient arrives in the ER. So between this alert that we'd put on the ambulances as well as the rule, the Connect Care rule, we feel we're going to be hopefully capturing the vast majority of Cyanokit orders on patients. So all of this work led to development of our CFlame protocol for handling and reporting Cyanokit samples. This is the flow chart summarizing the steps, and I'll just walk you through it just to give you an idea of what our techs would need to do in the lab. When Cyanokit samples are identified in the lab, either by activation of the Connect Care rule or a call from EMS, the samples will be held for our techs to follow the procedure to report results. However, we do have a fail-safe in case the samples are not detected by the rule or we don't get an EMS call, and there are some clues that we can use based on the studies that we've done. If the sample is red or appears hemolyzed visually, or if there's information in the patient chart that indicates Cyanokit was given, we're going to check the hemolysis index. And if the hemolysis index is less than 200, based on the hemolysis flagging study that I showed previously, the red discoloration is less likely going to be due to hemolysis, because with true hemolysis, we would expect a much higher hemolysis flag. At that point, we would call the ordering unit and confirm if Cyanokit is present. And then once confirmed, we would follow our reporting procedure. We would append comments to both reported and canceled tests to document that Cyanokit is present and to interpret with caution. And lastly, the protocol is deactivated after 6 days from the date of administration based on the hydroxycobalamin half-life, or earlier if the color reverts back to normal. So I'm approaching the end of this presentation, and just to conclude with some final statements, hydroxycobalamin imparts a reg pigmentation to plasma and urine that can take up to a week to clear. Interference is test and platform dependent. Laboratories should work with their ER, OR, pharmacy, and EMS to better understand drug indications and frequency in their hospital or health region. Multidisciplinary collaboration is required to find solutions for sample identification and result reporting challenges. And lastly, future work is needed to really fully characterize interference in vivo after the drug is administered in the patient. So not necessarily relying on our spiking studies where we're spiking it directly on the bench, really obtaining patients who have Cyanokit administered and comparing before and after the changes in test results. So with that, I'd like to conclude and acknowledge a number of individuals, my co-investigators who include Dr. Ablett Choi, clinical biochemist, Dr. Arthur Sotek, he's a hematopathologist who oversees the hematology and coagulation tests. A big thank you to the University of Alberta MLS student Stephen Dang, who performed the initial studies at the Misericordia Lab, Floria Yang, who then did the subsequent studies on the new instruments at the Grey Nuns Hospital Lab, our APL Epic Beaker IT analyst, Sean Sarasin. We have APL operations who supported the study, Richard Herndon, he's a Tech 2 at the MIS Lab, and Kristen McComb, a Tech 2 at the University of Alberta Lab. And these are the clinical biochemist collaborators that helped us with various studies, and our healthcare collaborators, including pharmacy and EMS, as well as Dr. Felix Sobelman at the MIS ER. So with that, I'll stop here and be happy to answer any questions.
Okay, we have no questions in the chat, so feel free to jump in verbally or raise a hand or type a question in the chat. We'll give a few minutes.
Josh, it's Gord Stewart, not a question, just a great presentation, thank you. I remember many years ago you reaching out to me about this and seeing if you could get the Cyanokit, so I'm glad that it worked out.
Yeah, great to hear from you. Thanks for attending. It's really been an evolution since we started back in 2019, and you know, I think if there's a will, there's a way, and an important collaboration with other stakeholders, not just in the laboratory, is key for this kind of study.
Okay, I'm not seeing any questions, so I would like to take the time to thank Dr. Raisman for his time. Remind everybody that I will be sending out an evaluation for this presentation right after we end here. And thank you for coming, and continue to look at the Covenant Health events page and for any future lunch and learns that we may host.